Hello everybody. This is a recap of commonly missed items from the 2024 ITE. I've broken this into two parts. I will be going through the first part of the keywords, and Dr. Eileen Kodak will be going through the second part of the keywords. So overall, fantastic job. You guys have really done a nice job the last 2 years. The ABA sends us these charts that track progress over the years. So the one on the left is for the CA3 class. You started your CA 1 year around about the 20th or so percentile. Last year you shot up over the 90th, and then you settled out somewhere around the 75th percentile this year. So good job, but now's not the time to give up. In preparation for the advanced exam, it's still going to require a lot of time to ensure that you guys successfully pass. The chart over on the left is for the CA2 class. I think I showed this during conference. You started out your CA 1 year way above the 90th percentile, and comically you're not even on the charts. But again, not the time to stop. The CA2 year, some folks can get a little bit complacent, so please keep working hard. Keep that line above the 90th percentile next year. So what this review is, keywords are included where at least one of the training classes had at least 10% below the national average. So somewhere there are some gaps. Each one of these keywords represents some gap that some class has. And so I've included these items in order to close these gaps. They're divided into 5 different sections. So they're the basic sciences, which is, of course, a basic topic. The clinical sciences, which are both advanced and basic topics. Organ-based and clinical sciences, which are both advanced and basic topics. The clinical subspecialties comprise only advanced topics, and then special problems in anesthesiology comprise both advanced and basic topics. Oh, I left out the CA1 class, which had a scaled score of 39.4, which is above the 90th percentile. So you guys are starting out well, but of course, basic exam is lurking, so please watch and close those gaps. Our first keyword topic is perioperative opioid requirements in those who are addicted. In general, this is an incredibly broad topic. Lectures on this subject could go on for hours and hours in general, and as you'll see with a lot of these keyword topics, it's a little bit challenging to summarize because I'm not exactly sure what the ABA was asking on the exam. However, I'll do my best. So this topic can be broken into several different categories of patients, and each of these patients are treated a little bit differently. So in general, you can divide patients into those who are in remission, not on medication management, and those who are on medication management, namely those on methadone, buprenorphine, and naltrexone. You can also have a category of those who are continuing to use opioid and not being treated. And of course, there are different recommendations based on different patient categories, as well as the severity of pain that's expected in the perioperative period. So in general, there are some usual recommendations for all patients who are addicted to opioids. In general, we try to maximize non-opioid adjuncts first, including regional anesthesia techniques whenever possible. For those who are on buprenorphine, there are different recommendations. So in general, oftentimes we try to have patients off of buprenorphine when coming in for surgery for 3 to 5 days to have maximum opioid effect. If this is not an option and patients either come to the hospital still taking buprenorphine or the surgery is unexpected, we can consider continuing buprenorphine during the perioperative period. We can also consider increasing the dose of buprenorphine or divide the doses into more frequent 6 to 8 hour intervals. We can also consider including the use of extended release or long-acting opioids for the short term. And then, of course, we can have these patients return to their usual buprenorphine prescriber to reinstitute the regular dosing schedule. Oftentimes in the perioperative period, reverting to opioids in general is required. We just have to be cognizant of dosing for those who are on these different therapies. Our next keyword topic is adverse reactions with antibiotics. So several topics related to adverse reactions with antibiotics do exist. We most commonly think about allergic reactions, but these aren't the only reactions that can occur with antibiotics. So the pictures below describe some of the adverse reactions we can have with specific antibiotics. So the one on the left describes C. diff colitis. We have a picture of a kidney here that is describing acute tubular necrosis that can happen with aminoglycosides. Fluoroquinolones can result in different rashes and urticaria. Angioedema can result with penicillins and other antibiotics. In regard to allergic reactions, about 1 to 4% of all administrations can result of beta-lactam antibiotics can result in some sort of allergic reaction, but only far less than 1% of administrations result in true anaphylaxis. Cross-reactivity between cephalosporins and penicillins is a topic that's often described. About 2 to 7% of those allergic to penicillins are also allergic to cephalosporins that describe any allergic reaction, but that number goes up when talking about true anaphylaxis. So if a patient comes to you with a true anaphylactic reaction to penicillin, which as we see above is pretty rare, you should be quite concerned for cross-reactivity with cephalosporins. Other cross-reactivity is fairly low with sulfonamides. Other sulfonamide drugs such as hydrochlorothiazide, furosemide, captopril, etc. has relatively low cross-reactivity with sulfa-based antibiotics. Our next keyword is femoral nerve block anatomy. This is a fairly straightforward keyword where a lot of different questions can be taken from. So the picture on the right shows an ultrasound image of what you might get when performing a femoral nerve block. So the structure all the way on the left, which is most lateral, is the femoral nerve. Going lateral to medial, you have the femoral artery, and then most medial, you have the femoral vein. Questions often arise regarding performing nerve blocks with nerve stimulation and how the needle should be redirected given a particular reaction. So when the sartorius muscle twitch is obtained, you should move the needle laterally and deeper. When you see a local twitch, the needle is most likely in the iliopsoas muscle or the pectineus muscle, which are deep structures, so the appropriate response would be to withdraw the needle. And of course, when you have a vascular puncture, since the nerve is the most lateral structure, you should remove the needle, of course, hold pressure, and then insert the needle more laterally. This keyword topic is on local anesthetic allergy. So in general, a true allergy to local anesthetics is awfully rare. And when it does arise, it's most often due to PABA, which stands for para-aminobenzoic acid. And this is a breakdown product that comes from really only ester type local anesthetics, which are far and away more elicit more allergic reactions than amide type local anesthetics. This is exceedingly rare. Sometimes people think of LAST as an allergy to local anesthetics, although this really isn't true. LAST is a administration of a toxic dose of a local anesthetic. This presents as either CNS toxicity or cardiovascular collapse, but is not considered an allergic reaction itself. The picture we have here is how testing is done for various local anesthetics. Local is injected underneath the skin, and skin reactions are then documented. Our next keyword here is risk ratio interpretation. So every ABA test will have some sort of question related to statistics, and this year's topic was risk ratio. So what risk ratio describes is the probability of an outcome in an exposed group versus the probability of the same outcome in an unexposed group. This idea is also known as relative risk, and a risk ratio or relative risk of 1 means that the exposure does not affect the outcome at all. Relative risk of greater than 1 means that the outcome tends to be increased by exposure. This can also be described as a risk factor, and relative risk less than 1 means that the outcome is reduced by exposure, which can be described as a protective factor. The image over here on the right sort of describes this in a pictorial way. I also included a screenshot from the mathematics section of the content outline. So if you are worried about this section of the exam, going through this list of different things and knowing what they mean and how to describe them is a quick way to prepare for this portion of any exam. All right, our next keyword topic is choice of crystalloid. So again, this is a very broad topic, and the most important thing to take away from this is to know that all crystalloids are not created equal. When administering a crystalloid, it's important to know what the content of the fluid is and to tailor it for each individual patient you're taking care of. So in general, crystalloid does have some common side effects among the various choices. So all crystalloid, if given in excess, will give you some degree of either GI and or pulmonary edema. It will result in hemodilution if given in large quantities. And then each crystalloid does have specific downsides. So for instance, lactated ringers is one of the characteristics is that lactate is converted to CO2 and to water. It's also a hypotonic solution. Plasmolite is perhaps the most balanced of the crystalloid solutions, although it does have a high magnesium content. Normal saline, as many of my attendings in training would always say, is that normal saline is not normal. It decreases the strong ion difference, which I've listed here, which ultimately can lead to a hyperchloremic non-GAP metabolic acidosis when given in high quantities, especially in the ICU. So just reviewing this chart over on the left briefly is important. Just to know what the contents of different crystalloids are, to know what it is exactly that you're giving each patient and how they will respond. Our next keyword here is effects of endobronchial intubation. So the image over here on the right was a little unclear, so I highlighted the main points. It shows an endotracheal tube extending into the right main stem bronchus, therefore not ventilating the left side, and we can see on the left lung there that there is an extraordinary amount of atelectasis and lung collapse. So some things that happen when an endobronchial intubation occurs are hyperinflation. So This will result in decreased pulmonary compliance and increased peak inspiratory pressures as well as plateau pressures. Shunting occurs, as we know from our time in the thoracic room. Whenever we ventilate only one lung, both lungs are still perfused, and shunt results when any perfusion without ventilation occurs. Now, this is counteracted somewhat by hypoxic pulmonary vasoconstriction, although this isn't 100% effective in reducing shunt. We can see also that with induction, there's a slower rise in FA over FI, and if we are depending on inhalational agents for induction, induction can be slowed when only one lung is being ventilated. Atelectasis can occur, as we see in this picture on the right. It becomes extremely present in the non-ventilated lung, and we can only overcome that when we perform recruitment maneuvers, because it requires quite a bit more force to overcome those atelectatic alveoli. Lung injury can also result during endobronchial intubation. If we've set our ventilators with higher volumes, we can incur volutrauma, and we can also incur barotrauma when high pressures are utilized. Our next keyword topic is interscalene block technique. So the interscalene block is performed at the level of the trunks of the brachial plexus. Our anatomy includes blocking these three trunks, the superior trunk, the middle trunk, and the inferior trunk, which correlate to C5 to 6, C7, and C8 to T1. Each of these trunks runs between the anterior and middle scalene muscles, as we can see on the ultrasound image on the far right of the screen. The anterior scalene muscle is the large muscle on the left. The middle scalene is all the way on the right, and then the three trunks we can see in the middle, we call that often the stoplight sign. The technique itself, patients will lie in the semi-supine position and turn their head away from you, the practitioner. The posterior border of the sternocleidomastoid is found. It's outlined there in marker on the patient. You are to then palpate posteriorly, finding the interscalene groove, and the insertion point is at the level of C6. Now, we don't often do this without use of ultrasound, and again, the ultrasound image that you should obtain is over on the far right side of the screen. So, in keeping with the interscalene block, we'll talk here about complications of the block. So there are both common and rare complications that come with the interscalene block. The most common complication is that in nearly every patient, the phrenic nerve is blocked, as the phrenic nerve contains inputs from C3 through C5. Therefore, in patients with significant lung injury, it's important to think twice before performing this block, because total pulmonary function can be reduced significantly, and those who are unable to make up for that reduction in pulmonary function may struggle. Rare complications that occur include pneumothorax, although this is incredibly rare given the fact that you are far away from the lung pleura. You can get the Bieshold-Jarisch reflex, which of course is bradycardia and hypotension that results from vasodilation and venous pooling, ultimately underfilling the ventricle and having the resulting bradycardia and hypotension. You can have nerve injury, of course. This is less common now with the advent of ultrasound, but it can still occur. You can get epidural and intrathecal injections, and then anytime we use local anesthetic, we do have to be cognizant of the dosing of our local, and you can certainly get local anesthetic toxicity. Our next keyword goes over one of the most feared public complications of anesthesia, which is intraoperative awareness. So intraoperative awareness does come with a set of well-known risk factors. They're divided into three common subsets. So these are patient factors, surgery type, and then anesthetic technique. Patient factors come into play. So folks who are chronic substance abusers are more at risk for intraoperative awareness. Medications that induce cytochrome P450 will also increase the metabolism of the anesthetics that we use. So the higher rate of metabolism means that patients are more at risk for becoming aware during their procedure. Those who undergo prolonged induction, such as difficult airways, we give a bolus of hypnotic agent, and then time passes. When we are focusing more on securing the airway, we often don't remember to redose medications, and these patients are then at risk for intraoperative awareness. Surgery type leads to a higher risk of intraoperative awareness for certain types of surgeries. So cardiac surgery is one of the most common. When folks are on bypass, it's the highest time for awareness. Any emergency surgery that occurs, and the reason for this is that folks who come for emergency surgery also often have depressed cardiac function, and we try to reduce the amount of anesthetic being given. Folks having emergency surgery are often hypovolemic as well, and so we try again to reduce the amount of anesthetics and further decompensation. Stat cesarean sections are often at higher risk for intraoperative awareness. For those of you who have ever been in a stat cesarean section, a lot is happening. The focus is on getting the baby out quickly, and oftentimes this can lead to the mother being aware of some or all of the event. Anesthetic technique is the last category that plays a role. So anytime we're using a total intravenous anesthetic, there's always the possibility of IV failure and the patient then not being able to receive anesthetic. When you combine this with neuromuscular blockade, the patient is not able to move as well, and to indicate that they may be aware of what's going on. And so folks who receive neuromuscular blockade are also at higher risk for intraoperative awareness. All right, the next topic is about one of the most feared intraoperative complications for the anesthesiologist, which is laryngospasm. So laryngospasm is the sustained closure of the glottis that makes ventilation either difficult or impossible. It is an involuntary response. It is triggered by input from the internal branch of the superior laryngeal nerve, and the motor input is via the recurrent laryngeal nerve. Now, the recurrent laryngeal nerve innervates the muscles that are listed down here in the picture. So the lateral cricoarytenoids adduct, the transverse and oblique arytenoids also adduct the vocal cords, and the thyroarytenoids tense the vocal cords. Now, why does this happen? So it most often happens with stimulation at a light depth of anesthesia. Folks who have reactive airway disease, such as asthma, those who are exposed to secondhand smoke are at higher risk for laryngospasm, and also younger patients are at higher risk for laryngospasm. So not surprisingly, the ABA went on to ask about management of laryngospasm for our next keyword. So I've put the flow chart on the right over here that we can go down in a stepwise fashion whenever laryngospasm does happen. But before we go down this, when we suspect laryngospasm, we have to know that clear communication in the room is key. You as the anesthesiologist will be the first one to recognize that laryngospasm may be occurring, and it's important to get as much help as possible as quickly as possible. So the first step is to apply gentle CPAP with 100% oxygen using a tight-fitting face mask. It's also important to give an aggressive jaw thrust, which helps to open up the soft tissues of the oropharynx. We can also perform the Larsen maneuver, which is sharp pressure at the angle of the mandible, which also has been shown to help loosen laryngospasm. We should aggressively suction the oropharynx. This can remove secretions that may be sitting around the cords, stimulating the cords to contract closed via the mechanism that we just discussed. And then ultimately, the branch in the road comes from our assessment of whether we're able to ventilate or not to ventilate. If we are able to get oxygen through and ventilate with a mask, this represents partial laryngospasm. We can overcome this by deepening our anesthetic, either with propofol or with inhaled anesthetics. If there is improvement, we can gently mask ventilate the patient through until they wake up. If there is no improvement, or if we're not able to mask ventilate appropriately and the patient starts to become bradycardic and hypoxic, this represents complete laryngospasm, which needs to be treated immediately. We can treat this with a low dose of succinylcholine, often 0.5 to 2 milligrams per kilogram, and often an anticholinergic such as atropine, which will help to treat the bradycardia that may or may not occur. Our next keyword topic here is monitored anesthesia care definitions. This seems like a straightforward topic, and it is, but it's very important that we review and understand what these different depths of monitored anesthesia care entail. So at the bottom, as I've written here, also providers must be able to rescue patients who progress one level of sedation deeper than anticipated. So oftentimes non-anesthesiologist physicians will be able to provide moderate sedation for various procedures, whether it's colonoscopies or cath lab procedures. And what this means is that these practitioners must be able to rescue patients if their intention is to give moderate sedation and they end up giving deep sedation. They must have the necessary skills to rescue them out of this state, which means that in deep sedation their breathing may be inadequate, so they should be trained in how to give a jaw thrust to support ventilation. Cardiovascular function is usually maintained, but sometimes a small dose of rescue pressor or fluid may be required, and so practitioners who are licensed to give moderate sedation should be able to rescue patients out of deep sedation. Now, briefly going through this chart, minimal sedation is a state that's often obtained by giving oral medications such as oral Ativan. The responsiveness is a normal response to voice. Airway patency, spontaneous breathing, and cardiovascular function are often not affected. Moderate sedation is a bit deeper, where responsiveness to voice is generally maintained. Airway patency is generally maintained, spontaneous breathing is usually adequate, and cardiovascular function is usually maintained. This can represent low doses of Versed or low doses of IV narcotic. Deep sedation is trending more toward general anesthesia, where responsiveness is usually only to painful stimuli. Both airway patency and spontaneous breathing may not be adequate, and patients may need an intervention to help them breathe. Cardiovascular function is generally maintained, although sometimes may need small amounts of support. General anesthesia is when a patient, of course, is unresponsive to verbal or painful stimuli, and half of the population is unresponsive to surgical stimulus. Airway patency and spontaneous breathing are generally affected, and cardiovascular function may also be impaired. Again, it's very important to review these charts and to understand the definitions, so take a few minutes and do so. Our next keyword topic here is differential sensitivity of nerve fibers to blockade. So this is a topic that commonly arises as well. And when thinking about this, there are several rules that apply here. The most important of which is larger nerve fibers are more resistant to blockade. Now myelin also comes into play here. And in myelinated nerves, we need at least 3 consecutive nodes to be blocked in order to completely stop conduction along that nerve. And so another way to think about this is the larger the nerves, the more space there is between the nodes of Ranvier, and therefore more local anesthetic is required. So if we look at the chart on the right here, we can see that our motor nerves are most resistant. These are large A-alpha fibers. And then our sensory nerves are more sensitive on down the line by size. So our sensory A-beta fibers are next, then our sensory A-delta fibers are even more sensitive. The nerves that are most sensitive are preganglionic sympathetic nerves, which are the C fibers. Again, looking at this chart, we can see that is true. Again, the larger the nerve fibers, the more they are resistant to blockade by local anesthetic. All right, our next topic here is recovery from neuromuscular blockade. This is a pretty broad topic. Many different questions could be asked, so this will just be a brief summary of what I think they may have been asking on the exam. Recovery and reversal from neuromuscular blockade can be accomplished in 2 ways. So neostigmine can be used as well as Sugammadex. Neostigmine is a cholinergic medication. It requires a paired anticholinergic, generally a glycopyrrolate, and it is only efficacious if we naturally have recovered from neuromuscular blockade to have at least 2 twitches in our train of 4. Neostigmine is a bit slower. It has a slower onset of action than Sugammadex. It takes at least 8 minutes for maximum effect. And then, of course, there's a ceiling effect of neostigmine. With increased dosing, we can actually top out the effect, and if we go beyond that, we may see increased weakness. Sugammadex encapsulates aminosteroid neuromuscular blockers in the molecule itself. It's more efficacious with rocuronium, but it also works with vecuronium. There is a lipophilic core with a negative charge that binds very, very strongly the positive aminosteroid molecule. Other topics regarding recovery from neuromuscular blockade could be the site of testing and also qualitative versus quantitative monitors. So the gold standard for monitoring is to have a quantitative monitor which shows a train of 4 ratio. We look for our train of 4 ratio to be greater than 0.9, and this indicates full recovery from neuromuscular blockade. The site of testing is also very important. So the ulnar nerve at the adductor pollicis is the gold standard. At this site, there is a slower onset of action and a slower recovery. So by testing here, we can be confident that the response to train of 4 stimulation will show us that the most possible recovery has happened. Our next keyword is thoracic epidural physiologic effects. So for procedures involving the chest or abdomen, we often perform a block that targets the thoracic nerve roots. This can be accomplished either by truncal block or epidural, both of which we perform at our institution. Part of what is blocked, which results in a lot of these effects, is the sympathetic chain that extends from T1 all the way down to L3. So many of the effects can be beneficial for patients undergoing major surgery, which include increased gut motility and increased ability to move, which ultimately results in decreased blood clots and improves respiratory function. Although, as we see here, this can be compromised if the block becomes too dense. We must be cautious also of reduction in afterload and preload, as block of the sympathetic chain can cause vasodilation, and impaired thermoregulation that can result as a part of this block in the sympathetic chain. So our final keyword in part 1 of the review is fluids and electrolytes in traumatic brain injury. So we must think about maintenance fluids in this situation. They should be warmed, they should be non-glucose containing, and they should be crystalloids. Our goal ultimately is to maintain euvolemia, and colloids are strictly avoided because with the increased blood-brain barrier permeability after an injury, colloids can lead to significant cerebral edema. Fluids can also be part of the treatment of increased ICP. So our first line agent is hypertonic saline. Our goal with hypertonic saline is to increase our serum sodium to the mid-150s to the point where fluid will be pulled from the brain parenchyma intravascularly. In a similar way, our second line agent is mannitol, which is an osmotic diuretic. Mannitol, however, can transiently increase our ICP as our intravascular volume will first increase before the diuresis takes place. Ultimately, though, the mechanism is similar to hypertonic saline, where fluid is drawn from the brain parenchyma into the intravascular space and then removed by the kidneys. We also need to aggressively treat hyperglycemia in traumatic brain injury, as hyperglycemia can increase the osmolality very dramatically. So tight blood pressure control is controversial, although at least blood sugar goals of 180 to 200 are definitely a good idea in traumatic brain injury. Okay, this is the end of part 1. Thank you very much for watching. I hope you all learned something and continue working hard and studying very well. Keep it up.